absolutely. Morena tātou, Josh, can I ask you to open up, please?
Of course. Tēnā tātou te tāne, kai aro te maru o te ātāhuatanga me ki o te rā. Nera timihini nui kia koutou, a me nui. Manawa mai te mauri nuku, manawa mai te mauri rangi. Kei au te mauri tipu, kei au te mauri tāwhito, kei au te mauri noke. No tiki tiki o rangi, no te wai oro oro o tāne te wai oro. Tēnei te mauri ka whakapiki, tēnei te mauri ka whakakake. Tēnei te mauri ka pota ki te whaiau ki te āmarama, ki te matatauira e tuake nei. Uhi, wero, tau mai te mauri, haumi e hui e.
Tairāwhiti. Morena tātou, welcome to those who are joining us on our live stream today. It's good to have you with us. Tuataki kei te mihi au ki a koe e hoa. Nau e tūwhera tā tātou hui. He mihi anu te ki a koe e hoa whānau. Kei te noho mātou, kei te noho. I'd just also like to share our greetings to Ingrid today, who retired from Three Rivers over the weekend, and just acknowledge her very long health service, both to the community and also to this. So, ngā mihi kia koe, Ingrid, I hope this gets back to you. So today we have Na joining us on Zoom, hopefully, not quite with us yet. And are we expecting Amy? Haven't heard. She may be running a little bit late with family things. Item 2.1, our schedule of interest. Does anyone have anything to update or so if they can just Rachel, and any conflicts in relation to today's agenda items? Oh, can't wait. Item 3.1, our public minutes from the 25th of May. They're at page 7. Does anyone have any comments on the minutes? Any corrections? No. Okay, we can adopt those as approved. And any matters arising from the minutes? No. Then we'll go to the actions from the previous meeting at page 13 and pass this one to you, please, Tim.
Yeah, so the first one, I'm still working on that one. Sorry, it's taking a little bit longer to see about that one. Nicola, you've got the second one around about the tracer app, and you've got some information here.
Firstly, I just have to acknowledge the detective work that my team undertook to try and find the right person and administrator, get the answer, which is the information is kept on the person's individual QR. They do not keep records that detailed at the centre.
So is it just that they scan, that they keep that there has been a scan so they can get the total number of scans?
Yeah.
Right.
So it did take us quite some time to work out for that.
Yeah. What about regional usage? What about just reporting on regional usage?
We've asked really specific questions and they say no, it's about the individual's QR scan. They could probably do it, but they're not giving us.
Yeah. And I guess they have been very concerned about people's privacy around the use of the app. Thank you.
So can I just ask on that paperwork that's signed when you go in, if you don't scan, where does that go? That written documentation, does the owner of the shop just keep it?
It's a register.
Yes.
Yeah.
It's a register, so they just have that in case they get a phone call to say that person.
They can actually go through and say on this day these people were here.
But it's just stays with the shopkeeper.
Well, unless you're contact tracing. And that's the purpose of it. So until they need to call on different sites, so like what Te Papa at the moment, anyone who signed in there would have recorded where they're from, their phone number and all that stuff.
Yep.
That goes to contact tracing.
Okay.
So expect the same principles apply, that it's confidential until it's needed. Okay.
Madam Chair, are we going to change these deadlines for all these action items, considering that the presentation was during April, etc., etc.? Should we update these deadlines so that they're a bit more maybe realistic for our CE and staff?
Yep. So we'll take advice on when that should be moved to.
I'm not sure actually about the ED one. Where are we? June, maybe August?
Okay.
Also, the conduct was made, it's not yet to be reviewed.
That one's closed now.
The code of conduct.
Oh, no,
No,
sorry.
not the code of conduct. The thing about the code of conduct is, well, we've got it from the Public Service Commission, and it was about lining up our code of conduct with the Public Services Code of Conduct. I'm just not sure if you really want to do that, given that this code of conduct is only going to last for 12 months.
Right. I guess it would be good to know if there's any red flags that are we can be out of sync with where the Public Service Code of Conduct is. But yeah, I do accept what you're saying now.
Okay, we'll check the lineup. Yep. And the last one's yours.
Yeah, so we've identified that our actions is against the immunisation rates, creation of the information for the cut-off point when someone has been late is 3 months. It's going to take us a little bit more time to do a deeper dive because it contains for the other component of the work to see who has been missed in Friday. Okay, if that's the case. So we've cleaned up ourselves on the
Okay. Does anyone have any questions on those action items? Okay, at 5.1, we've got no correspondence in this public session. And then 6.1 on page 14, we've got a regular performance dashboard. And just before we pass it to you, Jim, I did just really want to note that really good results on fast cancer treatments and newborn enrolment. So that's good news.
It is, and thank you for making comment about those. I guess the one that's is concerning there is around immunisation rates and the fact that we were making some good progress forward, but in that last month there, it's dropped back again, and I don't know what the reason is for that. We've had some correspondence from the ministry in general about immunisation rates and ensuring that we are applying attention to those, which of course we are. But I think that we do have to be careful at this time when we are focusing in on vaccinating our over 16 and over population for COVID-19, that we maintain the pressure on ensuring that our mokopuna are also vaccinated appropriately. So yeah, just to highlight that that's certainly on the radar for us and for the ministry.
So just on that, we did have a wee discussion about that at Iwi Tarangi, and thought that, maybe we could be giving some thought to how the non-regulated workforce who get trained as vaccinators might become a part of the solution here.
Yeah.
And we do understand that it's kind of slightly different because it's not like the mass vaccination like for COVID, but it just seems that we've got, a workforce coming on stream that both can vaccinate, albeit under supervision, and can access households. So if over time we can give some thought to how that might be able to be brought to bear on this particular issue we've got.
I see that, and we've got Liz here, in relationship to Better Help the Smokers to Quit. I'm not sure what might have happened there, Liz, just a little bit down for people coming through, but I think we've had some conversation about that, haven't we?
Yeah, I did some investigation about it, and a lot of it's down to the coding. So we've invited the coders to come to one of our meetings in maternity and to go through that. But with the percentages, for us, sometimes it's only a matter of 1 or maybe 2 that have missed, and that can be a woman that comes in, births and goes out with 2 hours. So the staff actually don't get any access to that woman. They're under the care of the LMC. And so we do get those women that do that. And I can't have a staff member running in and saying, oh, exactly, just before you leave, can I just throw this information in? But what I can say to you, because I've been overseeing all the hospital training for stop smoking, quit smoking online, that a vast majority of the staff are really taking this up now. So we've also put through for smokelisers, so that in the departments, when a staff member is discussing about quitting smoking, they can also use the smokaliser, which is a little, it's, what's it like a little asthma pump, but it's basically, it monitors their carbon monoxide level. And in maternity, we're going to have the ones that can inform the woman how much of that carbon monoxide is actually going across to a baby as well. And it's a really strong incentive to actually encourage these people to quit smoking. And it's what they use when we refer them over to Pinnacles, who are our local quit smoking providers. And that's what they use to monitor them, so that they can see that they're actually quitting smoking. We've also got the availability of going over to vaping as a method of NRT, because we know that vaping in this community is seen as something that's more acceptable. Now, we know that there are, you know, fors and against with vaping, but if it's used as an NRT product, it's actually, as soon as they start on that, the carbon monoxide level is gone, the toxins from the tobacco is gone. And it's the same as them having patches or anything like that. They can gradually wean off, and that might be more acceptable to them than those that have tried numerous times on the patches, the gum that they don't like and things like that. So that is good that we've got that here in Tairāwhiti and Waikato that are trialling that at the moment. So I'm hoping and praying that we can start to make a difference from the community perspective, the whole community in the hospital and out, because, you know, my passion with this is to try and reduce the number of hapu mama that continue to smoke and the effects that it has. But I realise it's actually wider than that. It's the whānau that sometimes are supporting that habit because they're smokers as well and don't want to quit. So that's what I've looked at, the bigger picture, and that's why I've taken this on board to be able to try and make a difference. So we shall see.
The other area that in there that I just thought would be good to just notice too is that around the diagnostic waiting times, clean sweep there again this month. So I know the amount of effort that's gone in from particularly in our radiology and our team around colonoscopies to make sure that that's going well. So it's good to note that that is successful. The ambulatory sensitive hospitalisation rate for Māori in our population has definitely reduced this year. We may not have reached the target around 45 to 64-year-olds, but certainly a good reduction in the rate there. Yeah, I think that's about it.
On that, Jim, you've got total population. I assume that's others, is it?
It's the total population.
Yeah. So while it's great to see the reduction in Māori, there's quite a significant increase in the others.
Yeah. I think that is, I think a factor in that is post-COVID effect of some people that may have had symptoms and conditions during lockdown period that have since come back into the system after that period of time.
I have a question relating to Liz's corridor, and that was, what is the MOH's position on supplementing vaping for cigarette smoking? Sorry?
For NRT, using it for nicotine replacement therapy, so it's supported for that. So there's a statement that we just was looking at yesterday, actually, because it came up in another conversation. So we were looking to see whether we needed to officially endorse that statement as a DHB that's come from the ministry around that.
So will that come back to us in due course?
Yes.
To have a discussion about?
Yep.
Great. Any other questions on the performance dashboard? Oh, okay. Just a very brief report from me this month. It's been relatively quiet. I know there's been the two Māori Health Koe planned, one that went ahead, and then the one at the end of, was it last week? Last week, seems like quite a long time ago now.
Friday last week.
Was deferred because of Wellington being in alert level 2. Chairs continue to meet with the Minister on a weekly basis, and the focus has been fairly consistent all the way through, still on financial sustainability and getting to the finalisation of our annual plans. Quite a strong expectation on chairs about supporting chief executives and senior staff during the transition period, and of course the vaccination program. So on the vaccination program, we have been assured of vaccine supply to work to 100% plan, and at the moment we're working to, I think it's 117% of plan is our total vaccination out to. Te Manuataki chairs met, and again it was a fairly standard meeting, but there is an evolving conversation amongst chairs about how we do more work as a region during the transition period in preparation for moving into regional divisions, Health New Zealand. We don't know if Te Manuataki will be our region, but we will work regionally as if it will be, because it can only help us to work in partnership with others. There's also a couple of other matters that I'll add updates in when we get to those on papers, particularly around some meetings that we've had with the ministry, a couple of matters during the month. And I think one of those I sent an update to you on during the course of the month. Na's not with us at this point. Yes, he is. Oh, kia ora wa. Nau mai hara mai.
Kia ora.
So just before I pass to you, are there any questions for me? Kapa will pass to you then now for the Te Waiora o Nuku Taimeme Chair's report.
Morena, kia ora everybody. Let's go straight to it. I picked up on some of your kōrero too, Kim. So the whakamaua training, we're very pleased with the level of attendance from Tairāwhiti particularly. It's a very good sign. A number of people talked about that as well. So just showing our want and interest to check up on the new reforms going forward. Tar Mason was brilliant as always. Really good actually, and probably the one thing I took away from his, or a lot of us did actually, was his drive to ensure that Māori participate at all levels of decision making, and so reinforcing the principles of the reform. So that was really good to hear. So that was the main focus of that. At our as a follow-up on our minutes, the board minutes from last month, we were just having trouble getting time to really get involved in the new TOR for Te Waiora o Nuku Taimeme, the terms of reference. So we're going to write draft ones and bring them back to our next meeting, but then as a base, use that to engage with iwi and their response to what a new Te Waiora o Nuku Taimeme might look like in the new environment come July next year. It's only a year away. And also wanted to take the draft equity position to iwi as well. So making that equity position direct from iwi in terms of how iwi see what equity means to iwi across the board, really, not just in health, but across the board, those things that impact. So we're going to try and organise that this very chilly month and see how we progress with that. I want to come back just to Heather and say apologies, Heather, we haven't come back to you on those requests for those audit questions yet, but we'll make an attempt to get through to those next month. Sorry about that. I think that's it, really, short and sweet. Now down.
Any questions for now? No. Okay, then we'll move to your report, Jim, at page 16 of the papers.
Thank you. I just started that off with that little snippet really there around nursing staff FTE. I know that's a topical issue across the country at present, amongst other things. Just really to show what has been happening around the growth in nursing FTE here in Hauora, Tairāwhiti over that period of time, both in terms of the paid FTE, so that's where we are on a day-by-day, shift-by-shift basis, altering the amount of FTE that we've got on the ground from our care capacity demand management, which you talked about last month, and response management on the day to make sure we've got the right mix and numbers of staff to be able to provide the care required, and then also underlying that the increasing rate of people with who are permanent employment within the DHB, and you will know and you will see that will continue to increase in the year ahead as part of CCD being fully implemented by tomorrow. So financially, the month wasn't a good one after last month's much better result this month. We slipped back into that same pattern of overspending in relationship to our budget. There was the same pattern in relationship to the increased work we're doing around catching up on planned care services, and we'll come to that report shortly. And the additional costs we've got around COVID for testing and for vaccination of people, and our other support systems that are in place for that, and the additional staff that I just talked about in relationship to care capacity demand management implementation. And we'll come later to our projections for the end of the year coming up tomorrow. There are a number of areas where we are that are within that result that are principally driving the variance, and I've got those listed there on page 17, middle of the page. We are very confident now about the additional planned care funding, and so we'll be releasing that as part of, or including that as part of period 13 adjustments that we'll be making to our financials. So just similar pattern there around our utilisation of services, a little bit down on medical admissions, acute admissions in the last couple of months, which is a good trend. But same pattern around emergency department, the numbers of people being admitted from there. Planned care on page 22, you'll see that record for us in terms of numbers of case weights delivered around planned care this year compared to those years back to 2012, and almost I think we're going to breach that record for actual numbers of people through, as well as besides the weight of the work that has been done for those people. Again, just noting there around meet the targets this month for faster cancer treatment and the strike. On the 9th of June. A lot of effort gone in there to make sure that patients and staff were safe over that period of time. So we're very appreciative of the work that was done. Long hours and dedication from so many people across that day, helping to make sure that was the case, and giving credit to our nursing staff who provided life-preserving services to make sure that was the case as well, and the working together to get through that period of time, and our expectations and hope that the work that's going on this week around negotiations will bring a resolution to that. Still working on the Waikato DHB IT outage in terms of disruption to services, although Waikato, as I've said there, it's got 90% of their services back up now. So certainly the issues like having to, our people having to go other places for radiotherapy has stopped now, and they're able to return to the Waikato services, which makes it much easier for everybody concerned. And changing and our systems and processes internally around prevention of such attacks, and also importantly our capacity to recover should our defence be breached. Planned care, really good trajectory happening there. That's the ministry's new word for it, in relationship to further reducing the numbers of people waiting for specialist assessments, and quite a significant reduction there between May and June of about 150 people less, and then down to 314 people waiting now, which is the lowest in that whole period of time back to December 19. So we've definitely moved past that effect of COVID last year and really getting into the backlog there. So that's taken a large amount of work, both from our own teams and also the support that we've had from visiting specialists and services to come in and help us with that, particularly around ENT services, which you will see there within the figures. And similarly there also for people waiting for treatment. The numbers of people waiting longer than 4 months is halved in a month. So yeah, you can see the work that's gone on to achieve that. And that will continue into 21-22. We've got again a commitment from government around additional funding to keep that work going in that year. And if we get back under 4 months for specialist assessments and for treatment, there's additional money that you get for achieving that. So that will be our target to achieve that over that period of time. Same picture within the emergency department. Good report back there around SAC1 and 2s this month. Yeah, what else? That's probably about the main points within there.
Does anyone have any questions for Jim?
The graphs on the nursing FTEs, I was concerned when I saw the drop off, but I see that it's a similar drop off a year ago. Is there something happens around this time of year to cause those drop offs?
I'm just going back to it, Andy, just so I can see. Oh, you mean in terms of a peak in around about February, March?
Yeah, and then we can drop off.
Drop off. Same in the previous year.
Yeah, I just wondered whether it's.
I don't know that there's a particular reason for that. That the paid FTE does have a lot of. It is much more month to month variation in that, depending on the numbers of people coming through over that period of time. I don't think there was. I know that I think that must be March. That there was a bit of a surge going on at that time, because I remember that we had many days there where the hospital was full. But clearly that hasn't been the case as much since that time.
The other thing was the 1.4 million off the bottom line. Is that likely to get assistance, or is that permanently off the bottom line? The COVID related 1.4 million.
Oh, the leave liability? No.
It's gone.
No. It's a liability sitting there. Yeah, eventually. Yeah.
Okay, thank you.
I think this is not unique to us. This is all unique to the health sector, actually.
Yeah, that actually was going to be kind of in the same line of question that I was going to ask. It was on page 17 in regards to the last paragraph and the financial, just talking about the public health expenditure reflects the COVID-19 costs not fully offset by revenue, which I was just going to ask for clarification to make sure I was reading it properly, which means that the revenue that we've received from MOH doesn't fully cover those COVID-19 costs, and so that offset that's not covered is coming out of our current budgets. Is that correct?
Well, it's contributing to our deficit, but we will get. I think before year end, we're expecting to get more revenue for that. Yeah.
Will the cost be fully
Well, I don't think that that the effect that's had on leave liability will be fully reimbursed, for instance.
And then my next question was in regards to SBs, again, great work being done there. Thank you for acknowledging that there's still a chunk there. Will that future program to help reduce those numbers also include support, again, like how we receive support from our Lakes colleagues coming over, especially in the ENT kind of space, help us reduce the SB rates, SB waiting?
Yes, there's still more work to do there. But we are recruiting a second ENT surgeon, so we won't need to. We're trying to. We've got an offer out. So if we were able to do that, then we'll have our own capacity and won't need to utilise that.
Oh, wicked. Prima.
Can I also want to say thank you to the hard work that staff have been doing to get these numbers down. Just a question about ophthalmology. What are the problems there specifically? That's on page 26. Is it a similar theme?
Well, Anil might be able to talk about that.
We're working, so we think we can clear the waiting list over the weekend.
Ophthalmology?
So we currently, I guess it's confidential in terms of we're still working with a private provider to work through that course, but we've been told that.
We'll talk about it a little bit more when we're in public.
All right, thank you.
Okay, any more questions of Jim? No. Okay, then if we move a bit now to maybe a bit more detailed discussion on the financial report at page 33.
Okay, Madam Chair, finance report. So as Jim sort of picked up, a not so good month. 756k adverse for the month. That's sitting us 3.7 adverse to budget year to date. So Jim's got a little summary down at the bottom of page 34, which reconciles year to date variance. That's up to Crown Holidays Act, 800,837 farm. So that's difference to what the farm act budget is and our expenditure, 427,000. I've just got the leave liability component of that 1.4 million. The balance is CME leave and plan care funding, which will be realising of 924. We've got the various arms of the DHB. Probably jumping over to page 38, where we've got capital expenditure. So it's tracking ahead of budget. Previous months we've been well ahead. Now we're behind the 8 ball of 400k, so that's quite good. We'll expect most of that to be sort of mopped up this month. Cash flow is holding up well, 3.7 million in the bank, and forecasting to be about 3.2 at the end of June. Still got 2 million out there for reimbursement from the ministry from our deferred capital expenditure, and forecast to year end on page 39. So still tracking it at 2.6 as of putting together the board papers. I've had conversations with our analysts. I've seen some good upside in our IDF outflows. So there's potentially about 400 to 500 gain there. So just asking a bit of a reconciliation on that. So we're looking to be better than the 2.4 adverse to budget.
My question, I think you've probably partially covered it, but if you can just maybe run me through it again. So at the moment we're 7.4 year-to-date actual deficit, but we're forecasting to be 6.6 actual deficit.
At the moment, yeah.
So what are the things that are going to get us back
to the beginning? So like I meant to say, IDF outflows.
Right.
So our net IDS. So that's still a moving target. We're always about a 2 or 3 month lag time from actual to forecast to our actual result. So they'll be washed up in August, July, August, September is that sort of time period. So what we're seeing from the last forecast is that we've got some upside there, or potentially around 400k. So not locking in 400k because until those wash up numbers come in. But that's the big one. There's some IBT, and I think there's some upside there as well. So we'll get a reconciliation done from funder analysts, and
Are they in the ministry?
No,
No, they're
Oh,
right.
ours.
and our team, yeah. So we're just working through month-end close for June at this time. So coming out outside of that, we'll have a better picture of what we're seeing.
And,
Some good news at this stage.
and then I guess going forward, what are the things that we can do with some of these areas that month on month and probably year on year cause us to breach budget?
Probably have more of the top half of the balance sheet or of the P&L, the funding increase would help.
But what can we do? Like, that's a bit beyond our control unless we're, getting more ACC work or something like that.
Yeah.
But what about on sort of the cost structure side?
Well, I think that's
So-
just
Well, if you just go back to page 34, with consolidated and just run down the red figures on the side of that, nursing personnel costs, we are implementing CDM, and those, the cost of personnel will continue to increase. But we are budgeting a higher amount for next financial year, and to reflect that some of that nursing management and business personnel cost overspend there is in relation to COVID-19 costs. So we are not budgeting for COVID-19 costs for 2020, 21, 22 because we're not expected to, but we will be funded for those. Outsourced services, that is where we do need to, where we've been paying for outsourced servicing, just as we've been talking about around us getting additional support for planned care services. So that's what's costing there, but so that is offset in part by revenue, but the fundamental there is recruitment and being able to recruit a full complement of our own staff in terms of utilising outsource around that. So there's a lot of work that's going on to improve that situation there. A lot of the issues around further down there around things like treatment disposals, implants and prostheses are also related to planned care work, particularly the implants and prostheses, additionals that we're doing there, and pharmaceutical costs we've talked about today. Hotel services, laundry and cleaning, I think that's an area that we unfortunately budget the right amount. Isn't that right, Craig? Yeah, so that's a problem there. IT systems and communications, I really don't have the detail there. The other operating expenses will be the non-specific accrual. And also I should mention that some of the personnel costs is in fact, probably the $513,000 is the accrual for Holidays Act. And and then when we get down to the area, the provider payments, around those areas, around all of those areas there within provider payments, a lot of that is affected by the additional revenue that we've received during the year being passed on to providers. So some of that will be COVID money that's come in and gone through us and gone out. So there's so that positive $9.7 million revenue positive at the top starts to go at the bottom there in a lot of those areas there around those personal health, mental health expenditure is the continuation of Te Wakaroa, for instance, in those areas at the bottom there. So in terms of the areas that we can focus in on, particularly around changing this position going forward, it is around ensuring that where we're implementing CCDM, that we're making sure we're doing that and meeting the requirements around that, but making sure we've got good matching between what the system is telling us we need to have there and what we actually have got in place, and utilising the systems within that. recruitment and retention around medical staff.
So can I, for going forward, it seems like the big issue is really our outsourced personnel, and probably some other HR issues. So can we have, as part of our regular reporting, either, and I'll leave you to make this call, whether it's as part of the performance dashboard or in a separate public excluded report, basically an HR dashboard that tells us what vacancies are, what the challenges are to them, just so that we've got a sort of greater visibility on this thing that's probably the biggest contributor to our ongoing deficit position. That'd be great.
Can I suggest it's more than just a dashboard though, that it speaks to the detailed actions as I mean, it's $4.8 million negative under outsourced services is fundamentally the answer to your question, Chair. I suggest it's got to be more than a dashboard. It's got to speak to the Chief Executive's key actions and, the organisation, culture and development that's going to lead us to a place where we have recruited and we're not outsourcing. Easy thing to say, hell of a challenge. So, but I think in order to actually have constructive conversation about what we can do, what options we've got to try and change that, I think it needs to be more than a dashboard so we can support them with the right conversations about organisation development or approach. I don't know what we can do in the current context, but it's got to be that kind of approach if we actually want to have a meaningful go at this.
Yeah, absolutely agree in regards to detail, and also details around our actual outsourced position as well, in a similar way that we got the SB details kind of brought back to us as well. So it really helped us help our CE and staff find out that stuff, right? But also, be good to hear the details about our actual outsourcing as well.
So maybe if we ask management to put together the first report for next month, and then we can provide feedback on actually these are yep, that's great. This is the additional information we want. We don't need to see that part of it, so that we can have one crack at getting the report refined as how we want it.
That's where clinical supplies as well. So with the supply chains drying up around the world due to the continuation of COVID around the planet, and the supply chain information that we're getting out of the centre is that expect a minimum of 10% increase. That's not including additional freight costs and clearance costs. So on a $22 million clinical supply, that's not insignificant. And it's
sort of work
that's a minimum 10%.
that we can change though, Craig, and those outsourced medical numbers have been huge negatives over many years, as opposed to COVID supply chain issues, which we may have limited.
Plus, we've got a funding increase of 5.48%, and we've got a cost increase of minimum 10.
But I would
have a delta.
Accept that, but it's
with clinical supplies. Well, we can't influence the cost of the supplies. What we probably do need to know is that we're not that we don't have clinical supply wastage.
Sure.
What I don't understand with that medical personnel budget line there is that last year the budget was 2.1 million and the actual was 4 million. Yet the budget for this year was 1.9 million. It dropped 200,000, and now it's actually 6.4. And I don't understand why when last year's actual was 4 million, we budgeted on less than half of that for this year. What was it? That sort of, I don't understand that. But we don't have to answer that here, but it does.
I imagine it was part of our drive to an agreed deficit level, and we went, right, we're going to go really hard to recruit.
Well, and also it's related to, if you look at the budget for medical personnel, employed medical personnel, the actual cost last year was 22 million, and we put a lot of extra budget in there because our expectation would be that we would be able to recruit into those roles, because at that stage when we were putting that budget together, this is pre-COVID times, the world was looking good. We were getting more people coming to this country. It was going to be yay. But unfortunately, of course, that's never transpired because those people haven't come. We haven't been able to recruit them, so we've relied on a scarce resource in this country, which is being extremely expensive, as is always the case with a scarce resource. Yeah.
And when we cobbled this budget together last year, I think we did it in the space of about 3 days from the agreed deficit. We stripped out 6 million out of the provider arm with, I'd say, zero consultation with clinical staff.
But that's likely to change now that we've got greater clinical support around.
No,
Oh,
I was just referring to the
time.
fact that we had to do it in 3 days, so you don't have time to get around and say to people, where do you think?
Okay, any more questions on the financial report, Andy?
Yeah, under infrastructure costs, there's an overspend of rents of 209,000. Rents would usually be budgeted and contracted, so what's that overspend?
On rents.
Mm.
Oh, okay, so that's our community accommodation that we provide. That we have to go and lease for locums, so just an influx of locums, and of course some might call it price gouging of landlords.
Supply and demand.
Yeah.
Yeah. So you're seeing supply and
doubled
demand in a
our-
number of areas in these reports.
Yeah, we've doubled our off-site accommodation for locums.
Thanks.
Okay, thank you. So we will note the financial report. There's no public items arising from our board subcommittees this month. But Chairs, is there anything you wanted to comment on this session?
Only from the FRAC that there has been a great improvement, and we congratulated Jim last week on the corrective actions for the internal audits, which was awesome to see some movement. Still a long way to go, so we can't rest, but definitely great improvement.
Okay. Anything from your perspective, Josh? No. Oh, okay. Then we move to item 7.1, the vaccination update, page 43.
So I'll just take the paper as read and to let you know that, we move at quite a pace, so there are some things that come in as we're actually writing the paper.
Nicola, do we know what our staff COVID vaccination rate looks like, roughly?
Not yet, but we're working on getting that. There's national guidelines around staff being vaccinated. So we've received those, and we'll work through that with our clinical leads around what that looks like for us. So that we'll do that in conjunction with that.
Because I have heard that, I was talking about aged care. The staff rates in aged care are looking actually quite good from their feedback.
Yeah.
We've had promising take all the way through the ACT services, and it's by no the generation of interest in the ACT providers for themselves and for their residents has been high right from the start.
They've got the most to lose.
Yes, they've had the biggest challenge when the infections came into the country last year, and so they've been really mindful. And their tech bodies have been very interested to keep the HBs on track. We've completed our second doses in HBs services, so it's pretty good achievement. Need to acknowledge Ryman, who linked their vaccinators into support the whole HBs services to be vaccinated. It's a really good offer.
Sandra.
Thank you. Interesting comments made at a function I was at over the weekend where probably most of the crowd was over 60 years. And I note in your report that general practice will be mobilised to invite people to come in for their vaccinations. It was good to see because they were all asking, why is my GP not providing this? So I don't know if that message has quite got out about this being a national health service rather than a GP service sort of thing, yeah?
So there were a few things that came together at the same time. We provided the information to general practice about how to support their constituents to get access to know when they were due to be invited, and then numbers as they needed. We also have the National Whakarongaro, which is the national call centre and booking system that was coming live into the same place at the same time. So we had this problem of two numbers, and so we had to time information going out fairly carefully and to what degree. We're also being guided by the Ministry of Health as to when we should do these things, and they keep shifting dates due to things that they were picking up. So and we think we're there now in terms of the information going out to general practice and then giving the right information to the right people. So we're working really closely with the PHO.
So general practice is now starting
They
to
should.
mobilise in that space?
We work through the PHO to engage with the general practice providers.
Thank you.
As we move towards tier 4, have we got enough vaccinators?
Vaccinators. We're still building our vaccination workforce. We estimated at the beginning that we'd need at least 50 for the big full push out to our communities. I think we're on track to be able to do that. They're coming in as part-timers, full-timers, they're coming in as a mix. So again, need to acknowledge Tairāwhiti and Tairāwhiti Health, who have really, through the floods, Tairāwhiti kept moving forward. We've had really sound support from Tairāwhiti Health who are about now to turn their gaze and work alongside us, coming into the end of the tier 3 and beginning of tier 4. So they've been our absolute backbone in terms of willingness to work alongside of the District Health Board and the vaccination program. Just that their total thinking, campaign, movement, whole work that they've been undertaking has been really well thought through. So
I think we absolutely need to recognise here too and give Tairāwhiti Health credit for being the first in the country to have vaccination assistance. I think today's the day when those people will start to be signed off and will be fully fledged. So I hope that gets, and I think that's going to get good coverage nationally around that, because the credit certainly is due there, and so that's adding a lot more vaccination. So I think with that we will be confident of having enough people to vaccinate for the next phase.
It's been, as we've indicated before, we've been building our team as we've been rolling out the vaccinations, and that work is still ongoing, and so we won't actually feel confident that we've got the right amount of people until we're actually delivering to tier 4 at the levels that we've said we will.
So does that mean that we've kind of a bit turned a corner in regards to hesitancy? We're feeling confident that we have still...
There's still people in our community who are choosing not to come forward in this first round, and we're just observing numbers in different parts of our community and thinking about what we need to do to generate an upwards interest. I don't think you can underestimate the influence that the anti-vax people have. They're in very interesting different places in our community. They're not necessarily identifiable as this is the target group, because we've got quite a few interesting pieces of feedback about why we won't be having a vaccination, and from people who you would normally think would be in that space to be welcoming wellness programs.
Having Dr. Susie Walls come regionally, that would have been helpful, having
Susie actually had we think, because Susie and Rawiri Jensen were up in Tairāwhiti. I think there was almost a full turnout from that community, and so that was a not private, but it was a locally driven exercise to up people's information and knowledge in that community, and so that was awesome in terms of the output there.
We do think that, as we move on, that momentum will gain. We've got momentum that will increase as the vaccine program gets out there, as people get vaccinated, that other people who may be hesitant at present will join in. And certainly that's the national surveys are showing that that's to be the case, that the proportion of people who are saying, I'm not going to get vaccinated, is steadily dropping. So we expect that to continue.
And I think we also need to acknowledge our iwi partners who've got quite a big comms effort going in vaccination program.
I think it's also very important to emphasise, the Delta variant aspect of this. I was hearing on the news last evening that there was a party in Sydney where 30 people were present, and now 24 of those people are positive with the Delta variant, and 6 people are not. They are people who are fully vaccinated, health workers. So, you know,
It's important.
come on, everybody.
Yeah.
You know, we don't want that in our community, and we're only a plane ride away from that.
As we've seen, Josh.
And in terms of the EOIs for sent out to GPs and pharmacies, how long is that EOI going to be?
Last week.
And we've received how many expressions of interest to?
We've had no actual response for the EOI. We've had an individual say, don't want to put anything in it unless I'm going to be, you know, unless I'm going to get it. Actually, it's a process that people need to understand what their facility needs to enable
In order to be able
to deliver. And so we're taking it at the moment that we weren't hopeful, can I say, we weren't hopeful. We were getting information back from particular general practice to say that they were probably not. We'd hoped that there may be some joining up of, say, pharmacy and general practice, but that didn't pan out. There's a set of guidelines that you have to meet to be able to deliver, and I think we know that there were visits to Kawhai in the interim by different groups to see what it looked like, and so we know that there was some interest, but we actually, the ability to not have it as a opportunistic immunisation. You've actually got to plan really well for the immunisation to occur. I think has been quite challenging for the current setup. I think in the future we're going to need to be much more open to thinking about these types of campaigns if we're in this.
But for what we're in now, though, that will no doubt mean that we are giving thought to site options for when we get to.
We've already given thought. So we're going to continue working with Ngāti Hauora on that side of the river. Tūranga Health has indicated there'll be some not permanent sites, but sites when they're going into communities. And we've also talked about Kaiti and Elgin as centres that will set up as well.
I think all along in our conversations with primary care, it's been around that is an option, but really their focus is winter, and what we all need as a community to be able to have good access to primary care services in winter, and so that's it's a very important thing to do. So we're grateful that they're focusing in on that, and the campaign can be mobilised and run without the need for primary care to be diverted from that really important focus.
Can I say though that while the providers have not necessarily responded, there have been quite a significant number of the teams that have supported the vaccination effort and are still working alongside of our teams.
And I guess just from my perspective, just wanted to reinforce those couple of messages that we are working ahead of our current plan. There is enough vaccine supply. We do have enough vaccinations, and they've been more on stream, and people will be contacted. Everyone can't be contacted on the same day, but people will be contacted as they become eligible. So just sort of wanted to just underscore those things. There's also very public reporting available on vaccination progress on the Ministry of Health website. And as Te Manawa-Taki would be forwarding around a Te Manawa dashboard to our boards as well. So there's a lot of information out there, and it's really important that we, as a board, steer people towards the right set of information.
Just a comment made from a faith-based framework was the feeling that for some people they would like to donate their vaccination to Fiji or that type of thing has been talked of just in regard to the poor communities in the world. And so I said, look, the way this is worked out, as you say, is through the ministry's discussions, but that was just a comment made through a faith network I'm involved with, and I don't know if that's going to affect them much, but that was just a dialogue from people feeling that there's poorer countries that could do with it.
So I think it's important to recognise that as a country we have donated PPE, AstraZeneca.
Right.
And as individuals, we can't go and get a vaccine
Post it off. Have mine.
in that way. But that's the support for countries like Fiji who are in need is happening at a national level.
We're being asked to up our focus on equity. And so I just wanted to share that we've started in our sort of community very quietly and at their pace. So just wanting people to know that that is now moving. And we've been working in those communities for about 3 months, just finding the right access doors and making sure that we are doing what the community would like us to do. First vaccinations given on
Kapai. Okay, thank you. Always a continued area of interest, not just for the board, but I think also for our community to hear how we're going with our vaccination program. So that brings our public session to a conclusion. So I'm now going to move that we go into public excluded. Thank you very much for joining us this morning, and trust that you'll join us again when we meet in our new financial year in July.